Starting.
Good afternoon to everybody. Today we will discuss the genital tuberculosis. I think you might be heard about the tuberculosis in the lungs, in the abdomen, and other areas. I think it is the new word for you because apart from other organs in the body, genital tract also is vulnerable to be attacked by the tuberculosis. We'll discuss about that. The history is not important for you. So, genital tuberculosis, which is very important, and the likely people that are involved by this are young teenage and young women. It is a disease of the young woman. 80% of are diagnosed between 20 to 40 years of age. TB is endemic in India. 5 to 10% of the infertile women suffer with the tuberculosis. The causative agent is Mycobacterium tuberculosis is 95% and Mycobacterium bovis is 5%. The genital tuberculosis occurs secondary to primary focus elsewhere. And that means primary focus may be in the lungs or in the abdomen or ileocecal area, whatever may be. Genital tuberculosis secondary to primary tuberculosis anywhere in the body. The most important that lungs are involved with 50% and lymph nodes are 40%, kidneys, joints, and gastrointestinal tract. And mode of spread is by hematogenous. Most common route is 90% of the spread is through the blood. And next is lymphatics. Next is direct spread. From infected abdominal organ or affected peritoneum. Directly it can spread or ascending direct contact with the infected sputum or sexual contact. See the pathogenicity, colonization of the genital tract, colonization of the genital tract and formation of the granulotomata, the viable TB bacilli, and they remain silent for a longer period in the genital organs and reactivation of focus at menarche. Usually, early menarche people, especially poor socio-economic, poor nutrition, the people are prone for genital tuberculosis. Genital infection acquired in childhood remains dominant till puberty. So the infection will be acquired in the early childhood but remain dominant till puberty. At menarche, active growth and increase in the blood supply of the genital organ, they actively grow and reactivation and establishment of the disease process can occur at a later age. Of all the genital organ, the most important vulnerable structures that are involved are especially in the reproductive organs of genital tuberculosis. Fallopian tubes are mostly involved, 80, 90 to 100%. And next tissue that is involved is endometrium, 50 to 60%, and the ovaries are 20 to 30%, and the cervix is 5 to 15%. Vulva vagina is 1%. This is the order of frequency of involvement of the genital organs. The sites of infection. So in the figure, site of infection of the tube, cervix, and ovaries, and the tubes. Tubercle bacilli infect the susceptible host. The primary reaction can occur. Polymorph nuclear inflammatory exudate can occur after 48 hours. Replacement by mononuclear cells and the cellular immunity will come into play and destruction of the tubercle bacilli and caseation, necrosis occur and then reactivation, classic granulomatous lesions can be seen. See the lesion, central caseous necrosis with the concentric layers of epithelioid cells, giant cells and peripheral lymphocytes, monocytes and fibroblasts. This is the granulomatous lesions by histopathological examination. The fallopian tubes, regarding the involvement, 90 to 100% fallopian tubes are involved in central channel for initiation and dissemination of the infection. Most common part affected the ampullary region. The least or no involvement is femoral or interstitium part of the tube. Spread is by hematogenous lymphatics and transperitoneal extension from nearby structures. And endosalpingitis. So whenever the tubes are involved, tubal mucosa is involved, favorable nidus and transluminal spread can occur. Exosalpingitis, diffusely spread miliary tuberculosis on the serosal surface. When you see the tubes by endoscopy, you can see the small miliary tuberculosis starting on the uterus tubes and ovaries and other peritoneal tissues. The tube is thickened to play consistency. We can see the enlargement of the tube by laparoscopy. On the right side of this thing, on the right side ovary is normal, on the left side the tube is enlarged and filled with the fluid. Tobacco pouch appearance is the typical characteristic feature of the involvement of the tube by the tuberculosis. Ampulla is dilated, sparing of the femoral end, and there is a pouting. So, tobacco pouch appearance. The tube is enlarged and the distended ostium remains patent with a recognizable averted fimbriae. This is the histosalpingography, which will give you the clue of the involvement of the pouch appearance of the tubes. And this is the pipe stem appearance of rigid pipes. See the histosalpingography, not previous slide also histosalpingography, not histopathology. Here also by doing the histosalpingography, they can see the scarring of the fallopian tubes, thinned, irregular and rigid filling defect in the uterine cavity. We can see because of the adhesions. Here also see the tubes are rigid like pipe. And T-shaped uterine cavity. Scarring results in a T-shaped uterine cavity with the extravacation of the contrast. If you put the dye, a iodine dye, because of the scar inside, the cavity will become like a T shape with the extravacation of the contrast dye into the tube. We can see the T-shaped uterine cavity. On examination, tubes are enlarged in diameter. The external surface is roughened, adhesions and grayish miliary tuberculosis we can see. Sometimes the tube is enlarged with the resort-shaped structure, 20%. On cut section, yellowish-gray caseous matter are hematosalpinx or pyosalpinx we can see. And microscopic examination involves full thickness at the tubal wall and ampullary focal or wide spread reactive adenomatous hyperplasia. We can see the and microscopic examination. While in stirring adhesions between the right tube and undersurface of the liver. Right tube and undersurface, this is called Fitz-Hugh syndrome. Those are adhesions between the undersurface of the right fallopian tube and the undersurface of the liver. Leakage of the infected matter into the peritoneal cavity and the peritubal abscess formation and tubular peritonitis and ascites we can see. The main is after fixation there is a formation of the fibrous tissue and adhesions. And reactive fibrosis, salpingitis, Salpingitis isthmic nodosa, occlusion of the tube as disease advances. Blockage of the blockage of the tube inside the lumen because of the adhesions, intratubular adhesions on the right side of the picture. Mucosa exhibits hyperplastic adenomatous pattern with a complex network of fused papillae. There is increased incidence of ectopic pregnancy. These are the women who are prone for ectopic pregnancy in the reproductive age group women. So, for all the cases of infertility, primary amenorrhea, secondary amenorrhea, it is our duty to rule out the genital tuberculosis. Tuberculosis of the involvement into the endometrium, that is called tuberculous endometritis. It involves 50 to 60%, and it is a descending infection from the tubes, and corneal ends first to get infected because of the entry. On examination, no remarkable changes in most of the cases due to cyclical menstrual shedding. Occasionally, there is ulceration, granular, and fungation lesions we can see. Sometimes the uterine cavity appears smooth and devoid of endometrium, and destruction of the endometrium may lead to amenorrhea. They will go into primary amenorrhea or secondary amenorrhea depending on the period of destruction. Uterine cavity, there is a shrunken due to underlying fibrosis. They may form a lot of adhesions and forming Asherman syndrome. And tubal ostia appears recessed and narrowed. Tubal ostia will become gulf hole appearance. Tubal ostia appears recessed and narrowed. It will become small. Tuberculosis of the endometrium. We can see on the uterus tubercles of the basal layer of the endometrium shed at each menstruation, and there is a possibility of the reinfection, endometrial ulcerations, and adhesions formation leading to Asherman syndrome. So there is a shedding of the endometrium, and there is a reinfection, and again adhesions formation. These are the process. Now coming to the tuberculosis of the ovary. The ovaries are involved 20 to 30%. The spread is from the adjacent tubes. Periovaritis, ovary encased in adhesions. It is embedded in the adhesions. Hematogenous spread, caseous granulomatous in parenchyma. Suggesting granulomatous in parenchyma, we can see the hematogenous. See in the laparoscopy, you can see the tubercles, the tubes, and also uterus is congested. The ovaries appears to be very enlarged and edematous. Tuberculosis of the cervix. It is very rare. The incidence involves 5 to 15%. The spread is primary source is from the husband, and secondary is descending infection from the uterine cavity. On examination, we can see the polypoidal hypertrophic lesions, mimics like a cancer cervix, and ulcerative lesions, yellowish brown, offensive discharge may bleed and touch. The polypoidal hypertrophic lesions will be there, and ulcerative lesions will react to hyperplasia of the glandular epithelium. Papillary formation also is there. React to hyperplasia of the glandular epithelium. And on microscopy, we can see the scar granulomatous lesions with a lot of lymphocytes. Tuberculosis of the cervix, it is congested, and also there's a edematous and hypertrophied cervix, we can see. TB of the vulva and vagina, it is very rare and involve only 1% of the genital tract. The spread is from direct spread from the genital tract lesion, the exogenous infection. The Bartholin gland alone may be affected unilaterally, causes induration or abscess formation. And vulval lesions discharging Ulcer and sinus or nodular hypertrophic lesions are seen in the vulval area. Vaginal nodule ulcerates and discharges sinuses. The diagnosis is cervicovaginal smears and ulcerative lesions we healed by fibrosis, and we can see the vaginal stenosis, and rare complications are rectovaginal fistulas are very, very unlikely. And because of the involvement of the vagina, the whole tissue will be replaced and the vagina will become stenosis. Tuberculosis of the vulva and vagina is the rarest form of genital tract. Sexual partners may be a source of infection. And in the vulva, it begins as a nodule on the labia or on the vestibular region, breaks down and irregular ragged ulcers, sometimes with the sinuses discharging caseous material and pus. As a hypertrophic irregular watery growth can be seen in the vulval area, and in the vagina may simulate a carcinoma in gross appearance. Clinical features of the genital tuberculosis: 10 to 15% it is asymptomatic, and general symptoms like weight loss, like any other genital tuberculosis of the like in medical department, fatigue, low grade fever, littleness should rise. The rise of temperature, evening rise of temperature is the suspicious of unsuspected tuberculosis. Clinical features are mainly, most of the women will present with a 35 to 40% of the women will present with infertility, and menstrual irregularities can see in 10 to 40% of the people. Mostly with pain abdomen and chronic pelvic pain we have to suspect the genital tuberculosis, with this chronic pelvic pain will not subside by like a normal antibiotic therapy. The vaginal discharges we can see the abdominal masses, tuber-ovarian masses, or ectopic pregnancy is most likely to be a cause of the cause is genital tuberculosis. There is a formation of the fistula, and the investigation that can be done for the genital tuberculosis is complete blood picture, presence of lymphocytosis, and the ESR is really non-specific, and Montos test is positive, indicate exposure to tuberculosis bacilli in the past. And quantiferon is a test that is superior to Montos. Ultrasonography will reveal the abdominal masses, and also ultrasound guided fine needle aspiration cytology can also be done with the under ultrasound guided. And chest X-ray to detect the site of primary lesion, tissue biopsy, local excision tissue biopsy from the lesions of the genital tract on histology, diagnosis of tuberculosis. Local excision tissue biopsy from the lesions of the genital tract on histopathological examination will clinch the diagnosis of genital tuberculosis. Endometrial histology, we have to do endometrial biopsy in late premenstrual phase. Tissue obtained from DNC or hysteroscopic biopsy. Classical granulomatoous lesions seen in endometrial sampling on day 24 to 26 of cycle or within a few hours of the onset of the menstruation. Classical granulomatous lesions seen in endometrial sampling the day 24 to 26 of cycle or within few hours after the onset of the menstruation is the best time for diagnosis of tuberculous endometritis. The biopsy specimen will be sent to the histopathological examination. Endometrial scraping divided into three portions. One is for histopathological examination. Second, for PCR testing, rapid, sensitive, and specific to detect mycobacterial DNA. Results obtained in 24 hours. DNA PCR we have to do. It can detect fewer than 10 organisms in clinical specimen compared to 10,000 necessary for smear positively, and guinea pig inoculation and culture on the three. But this guinea pig inoculation we are not doing. We are doing only histopathology and also for DNA PCR. For culture also we are sending the specimen. Histopathological examination, reliable and specific method of diagnosis of tuberculosis with a sensitivity of 10 to 100% is slide examination with a high specificity. See, epithelioid and Langerhans giant cells are and lymphocytes is the diagnosis of tuberculosis. CBNAT is a cartridge-based nuclear acid amplification technique. Results will come within 2 hours. It is a molecular test. Histosalpingography. This is performed in asymptomatic women, especially who will come for infertility or a secondary amenorrhea. After getting the periods, will ask to have an histosalpingography. It is contraindicated if suspected genital tuberculosis. The risk of spread of infection is more. The features are beading and filling defect we can see by histopathological examination. And we can see the corneal blocks and ragged fluifishness of the tubal outline. Fluifishness of the tubal outline, we can ragged appearance. And calcification of the tube, we can see sometimes a tobacco pouch appearance of the hydrosalpinx or pyosalpinx. Rigid peristaltic pipe-like tube, lead pipe appearance of the tubic tube. These are the features of the histosalpingography by radiological features for the diagnosis of tuberculosis of the tubes by histosalpingography. See we can now see this thing uterine cavity in the first picture, and the third we can see the gap in the uterine cavity, and also the tubes are like a rigid. Here we can see the hydrosalpinx. The other one is like the pipe. We can see then the right tube, very long and lengthy. Absence of the tube on the other side. And histoscopy. If you do the histoscopy in tuberculosis patient on treatment or for the diagnosis, ostia not visualized, that both ostia are closed, that become fibrosis. Mucous material coming out of the ostia we can see sometimes, and periosteal fibrosis. We can see the fibrosis around the tube, around the medial end of the tube. And the cases in tuberculosis we can see endometrial calcifications also we can see, and scanty endometrium. Endometrium may not be seen complete, is very scanty, little. Intrauterine adhesions we can see in the endometrial cavity, and irregular uterine cavity we can see through the hysteroscope. These adhesions are nothing but because of the fibrosis of the tuberculosis endometritis. And we can see the irregular uterine cavity because of adhesions. On the laparoscopy, to establish the diagnosis of abdominal pelvic tuberculosis, TB lesions can be seen on the parietal peritoneum, intestinal serosa, omentum, tubes, uterus, and hydrosalpinx, and pyosalpinx, tubovaran masses. We can see the TB lesions anywhere in the genital tract. Abdominal pelvic tuberculosis. Histology and PCR testing from selected tissue biopsy helps in the diagnosis. Advanced pelvic tuberculosis by laparoscopy, you can see a lot of additions which has Curtis or abdominal tuberculosis. There's a lot of here also by see the hydrosalpinx and also additions. And here and the whole intestines all become like matted. And other tests that are gas chromatography is a direct demo of components of the mycobacterium. Soluble antigen fluorescent antibodies test we can do. Rapid culture method, radioactive carbon labeled substract, formic acid or formic acid used takes 5 to 7 days. And semen culture, in the presence of vulvovaginal lesions, we can see the semen culture also for tuberculosis. Gene expert now new test that were introduced for the diagnosis of drug resistant TB is based on PCR. And biochemical markers are we can send the ascitic fluid for adenosis deaminase, highly specific and sensitive. And ELISA test for IgG and IgM. X-ray of the bones and joints also we can send. Differential diagnosis of this is an ovarian cyst, broad ligament cyst, and encysted fluid. You can see differential ovarian cyst and broad ligament cyst and encysted fluid, chronic pelvic inflammatory diseases, and ectopic pregnancy, carcinoma of the cervix, and elephantiasis of the vulva, and pregnancy. Because in tuberculosis, midline swelling will be there. It looks like a pregnancy only. Puberty, menorrhagia, and postmenopausal bleeding. In the early stages of genital tuberculosis, the patient will have menorrhagia because of the high congestion and inflammatory reaction, fungal infections, and sarcoidosis. And the treatment part is one is chemotherapy and second is surgery. The chemotherapy is anti-tuberculous drugs. The first line of drugs are rifamycin, ionized pyrazinamide, and ethambutol. And second line of drugs is caprimycin, kenamycin, and ethanamide, para-aminosulfuric acid, cycloserine. So the dosage of rifamycin is 400 to 600 milligram daily, but the side effect of the drug is hepatotoxic, pruritic rash can occur, orange-colored urine can appear. And INS is 300 milligram daily, a single dose, and hepatotoxic and peripheral neuritis and hypersensitivity will be there. Pyrazinamide 1.5 to 2 grams divided doses, hepatitis hyperuricemia can occur. Ethambutol 15 milligram per kg body weight per day, optic neuritis and skin rashes are common. Rifamycin interferes with the OC pills absorption. That short course therapy for 6 months, initial phase 2 months, and Hajj is 3 times a week, continuous phase is 4 months HR only. And the resistant cases, we can 8 months we can diagnose the first two. In resistant cases, we can treatment for 8 months. First 2 months Hajj plus yes, and third month Hajj. Remaining 5 months HRE we can give. That is a short course therapy, and also for the resistant cases, we can give long-term therapy. And surgery, what is the role of surgery in tuberculosis? One is indication. Despite of chemotherapy, if the patient is having persistent active lesions and progress of the disease, persistent large inflammatory masses like pyosalpinx and pyometra, and persistent symptoms, that pain and amenorrhea, and persistence of fistula. And the contraindications are active lesions elsewhere, additions of the bowel, and chemotherapy given several weeks before and full course after surgery. Types of surgeries: removal of the adnexal masses or tubovarian masses, total hysterectomy with bilateral salping of rectomy. If the patient has completed the family and nearing to the 40 years, and drainage of the pyometra, and vulvectomy, the hypertrophic vulva, and we can do the valvectomy, we can do, and fistula repair if there is a rectovaginal fistula. Follow up the case for 5 years yearly or when indicated early curate to check the reactivation of the tract. HSD is contraindication. Reactivates dominate the infection. The prognosis is fertility only 10% in all cases of genital tuberculosis. One third of patients may go into abortion, and 50% will land with an ectopic pregnancy. Only 2% will have a live child. This is all about the genital tuberculosis. So we should take care of that, especially in the teenage girls and young girls. We should always have an eye on the genital tuberculosis whenever they come for infertility or primary and secondary amenorrhea. As a preventive measure, they have to improve the education of the woman. Second thing is improve the socio-economic status and counseling regarding the diet, regarding the hygiene, regarding especially the menstrual hygiene, and improve on the whole of the general condition of the patient by improving the iron and improve the hemoglobin by iron. So prevention is better than cure. This tuberculosis may damage the reproductive tract completely. So better to prevent and get treat the patient by diagnosing at a early stages. Thank you very much. And take home message is the physician should be conscious of the entity. One should suspect and exclude genital tuberculosis in the following: unexplained infertility or whenever they come with amenorrhea, recurrent episodes of pelvic infection, not responding to usual course of antibiotic, should always have suspicious. The presence of pelvic masses with the nodules in the pouch of Douglas. So these are the take-home message you have to take. Because tuberculosis is an airborne disease that is transmitted from person to person, it knows no borders. To end tuberculosis, we should continue to work together to fight this epidemic and prevent the woman world. Thank you for giving this opportunity. Thank you.